The fluorescent lights of St. Michael's Trauma Bay hum like fluorescent lights always do at 3 in the morning, a sound most people never notice because most people aren't awake to hear it. Hannah Clarke hears it. She hears everything. The ventilator's mechanical wheeze from Bay 2. The barely suppressed panic in the resident's voice calling for a crash cart. The soft click of the medication lock clicking open as she verifies the drug against the patient's armband. Hand steady as a surgical laser, she moves through the bay restocking supplies that shouldn't need restocking but always do, her movements efficient and silent as a woman who learned long ago that competence doesn't require announcement. The limp from her left knee is barely noticeable at this hour, when adrenaline overrides pain and the hospital is mostly empty enough that she doesn't have to pretend to move any differently. 3 years. 3 years she has worked the night shift at St. Michael's Hospital in Atlanta, and not once has anyone asked why a woman with her clinical intuition, her ability to anticipate a patient's decline 3 minutes before the monitors scream about it, works nights restocking crash carts instead of leading a department. She prefers it that way. The preference is not incidental. Her scrubs pocket carries 2 things, a photograph the size of a playing card and a faded unit patch, the edges worn soft from being handled in the dark. The photograph shows a young man in army dress uniform, James, killed at age 23 in a valley whose name she will not think about during working hours. The unit patch is from the 3rd Special Forces Group. She found it years ago, sewn into a jacket lining, and kept it without ever explaining to anyone why. The hospital has no idea who Hannah Clarke is. The hospital has every reason to keep believing that ignorance. That arrangement has suited everyone until approximately 6 weeks ago, when Dr. Marcus Pierce decided to take closer notice of the quiet nurse who moved through his patients' lives with the calm of someone who has held people together while worse things were happening around them. Pierce is a cardiac surgeon the way expensive watches are expensive, because someone decided to charge an obscene amount of money for what other people do for considerably less. His credentials hang framed in his office: residency at Hopkins, fellowship at Johns Hopkins, board certified in thoracic and cardiovascular surgery, American College of Surgeons, the whole architecture of privilege built on the foundation that credentials equal competence, that a name on a diploma means something that a person without the name lacks. He has never held a patient's hand through their last breath. He has never felt a femoral artery pulse stop under his fingers because he did everything right and sometimes the body decides otherwise anyway. He has never stood in the rain at a bus stop in a city that wasn't his home, holding a cardboard box that was already getting soft, and understood what it meant to ask for nothing and still lose everything. But he watches Hannah Clarke work. He sees it first during a code blue in the trauma bay at 2:45 in the morning, when a motor vehicle accident has delivered a patient with a pneumothorax that should have been caught in the field but wasn't, and the monitors are climbing and falling like stock prices during a crash. The junior resident, a boy named Patterson who is smart enough but green enough to wear his panic on his forehead like a billboard, is fumbling with the chest tube setup, his hands not quite remembering the sequence, and he's been trained but he hasn't yet learned that training and muscle memory are not the same thing. Hannah is there. Not called. Not paged. Just suddenly present with a level of calm that sounds like a tank idling in a garage, her voice moving Patterson through the steps, 14-gauge angiocath. Find the second intercostal space, mid-clavicular line. You're looking for the hiss of air. She's not touching him. She's not taking the equipment away. She's simply speaking, and Patterson's hands find their confidence in her voice the way a ship finds a lighthouse in the dark. The needle goes in. The hiss comes. O2 climbing. 75. 82. 88. Stable. The senior resident watching from the corner doesn't make eye contact with Patterson afterward because that would acknowledge that a nurse just taught him something he should have remembered, and that's not how the hierarchy works. Pierce watches all of this and feels something like heat climb up the back of his neck. It happens again 2 weeks later during a post-op complication with one of Pierce's own patients, a woman 3 days past a valve replacement who is running a fever that shouldn't be there. Pierce rounds at 6 in the morning, the time when he likes to round because there are fewer people around to witness him being wrong about things. The patient's vitals look stable, the incision looks clean, no obvious signs of infection, so Pierce nods and moves to the next room. Hannah is at the medication cart, and she says nothing. Not directly. She simply mentions, in that low voice that carries no judgment and all of the weight, her lactate was 2.1 yesterday. I checked again at 4 this morning. 2.8. She doesn't say what that means. She doesn't have to. Rising lactate in a post-op cardiac patient means infection is climbing somewhere. Pierce's eyes haven't looked yet. Pierce doesn't respond. He walks back to the room. He orders labs he should have ordered 6 hours ago. The culture comes back positive for staff that will require 3 weeks of antibiotics and 1 serious conversation with his outcomes committee. He is a cardiac surgeon whose outcomes have just been impacted by the clinical insight of a nurse, and his face does something that resembles a smile but tastes like battery acid. The decision hardens in him the way bad decisions do, with a feeling of inevitability. She is a threat. Not a physical threat. A threat to the architecture of the world he has built, where credentials equal knowledge and titles equal authority, and a man with the right last name and the right education is supposed to be the smartest person in the room. Hannah Clarke, with her combat calm demeanor and her ability to see what's happening inside patients before the monitors have the courtesy to announce it, is suggesting that the architecture is built on assumptions rather than facts. She is suggesting that competence is competent regardless of whose name is on a diploma. She is suggesting that a woman who restocks crash carts at 3 in the morning might be worth listening to, and Pierce has spent 42 years avoiding conversations like that. He begins in the way powerful people begin, which is quietly. A phone call to a friend who works in recruitment. A question, casual and almost offhanded, "Hey, do you know anything about a nurse named Hannah Clarke? Works nights at St. Michael's. I'm hearing some concerning things." Nothing specific. Just, "Can you do a background check?" The voice on the other end of the line, a man who owes Pierce money from poker games and favors from several divorces, agrees without needing to understand what he's looking for, because that's how power works. It works by proximity and obligation and the assumption that questions without answers probably have reasons worth finding. Hannah has no idea this conversation is happening. Hannah is restocking the crash cart in Bay 4, her movements precise and economical, her mind somewhere else entirely. Her knee aches. She ignores it. Pain is information, and sometimes the information is just that you're tired. But that wasn't the worst part. The worst part was that Pierce, being competent before he became anything else, wasn't just making phone calls. He was watching. He was waiting for the moment when Hannah's confidence would slip, when her clinical insight would fail, when something would happen that he could point to and say, This is why she doesn't belong here. This is why the hierarchy exists. This is why a nurse is not a doctor, and credentials are credentials, and some things cannot be questioned. He was waiting for his opportunity. And he was patient enough to understand that opportunities, like infections, have to be allowed time to develop before you can treat them properly. The Grand Rounds Amphitheatre at St. Michael's holds 20 medical students on Friday mornings, and today Dr. Marcus Pierce is orchestrating a masterclass in humiliation disguised as education. Hannah stands in the back corner, where she always stands, visible but invisible, the way nurses are trained to occupy space in rooms that don't truly want them there. Her badge reads simply H. Clarke, RN, because the credential beneath it doesn't exist on any official record. Pierce clicks to the next slide. It's the case file from 2 weeks prior. Patient in room for 27. Acute myocardial infarction. Post-op day 3. He reads the notation in Hannah's handwriting, consider reducing anticoagulant dosage per patient's renal function. Creatinine elevated. Standard protocol may cause bleeding complications. The students lean forward. Pierce smiles like a shark that's caught the scent of blood in the water. This, he says, holding the chart up to the light, is what happens when someone mistakes confidence for competence. When they believe their nursing intuition, their gut feeling, supersedes evidence-based medicine written by people with actual medical degrees. His voice carries the practiced warmth of a man who knows exactly how to make cruelty sound reasonable. Nurse Clarke here thought she might improve upon decades of established protocol. Our wannabe MD, if you will. Scattered nervous laughter from the students. Hannah's jaw tightens. Just barely. a motion like grinding stone beneath her skin. Pierce continues. What happens when someone watches enough Grey's Anatomy and decides they understand pharmacology? When they forget that there's a reason we have hierarchies in medicine. He sets the chart down with theatrical deliberation. There's a reason doctors go to medical school, ladies and gentlemen. Not everyone can make these decisions. Not everyone should. One of the residents glances back at Hannah. She's staring at the floor. But her hands are completely steady. No trembling. No defensive crossing of arms. Just a nurse in scrubs, taking notes on her shift, absorbing the public dissection with the kind of calm that only comes from having already endured worse. Pierce looks directly at her now. The kill shot. Nurse Clarke? Would you like to explain your reasoning? Perhaps you can educate us all on your medical training. Hannah looks up. Meets his eyes. Takes one measured breath, the kind that sounds like iron settling into place. The patient lived, she says quietly. Voice flat as a hospital floor. Because someone was paying attention. The silence that follows is the kind that doctors hate. It's the kind that makes residents wonder if their attending just lost a round. Pierce's smile doesn't waver, but something behind his eyes hardens like cooling metal. He's not used to being challenged. He's definitely not used to being challenged by someone in scrubs. Exactly my point, he says, but the warmth has evaporated from his voice. This is dangerous. This is the kind of independent thinking that gets patients killed. He turns back to the students, but Hannah can see his hands have gone white-knuckled around the laser pointer. Protocol exists for a reason. The presentation continues for another 20 minutes, but the students aren't really listening anymore. They're watching the temperature of the room, the way Pierce's eyes keep flicking back to Hannah, the way his voice has taken on a harder edge. Some of them are writing notes. Not about the case. About the interaction. Hannah finishes her shift 6 hours later. The evening crew has arrived. She's stripping off her gloves, already thinking about the drive home, the 2.4 miles through Atlanta traffic where she won't have to maintain composure, where she can let her shoulders drop from wherever they've climbed to, when Pierce appears at the vending machine on the third-floor corridor. He's not alone. 2 junior doctors are with him, reviewing a chart, laughing about something. They don't notice Hannah at first. She shouldn't approach. She knows better. But room 340 is right there, and the patient, Henderson, 73, post-op day for his renal panel is concerning, and the anticoagulation protocol Pierce ordered this morning is going to cause exactly the kind of complications that protocol is designed to prevent. She walks up to him. Professional. Measured. Dr. Pierce, the anticoagulant dosage for the patient in 340. Given his renal function, creatinine's elevated, we might consider. Pierce's voice explodes into the corridor like shrapnel. Are you practicing medicine without a license? The junior doctors freeze. A nurse 3 doors down stops mid-stride. Somewhere, a heart monitor continues its steady electronic pulse, indifferent to human drama. I will call security, Pierce says, his voice now pitched for maximum projection, and have you escorted out if you ever presume to override my medical judgment again. Do you understand me? Hannah's breath catches. Just for a moment. Just barely. Her hands remain at her sides. She doesn't step back. Doesn't retreat. Her eyes stay level with his, and what happens next is so small that only someone trained in reading human behavior, someone who's spent years watching for the microtel, the tell that separates living from dying in a combat zone, would catch it. A single tear escapes her left eye. Just one. She doesn't try to hide it. Doesn't blink rapidly or look away. She simply wipes it away with the back of her hand and holds his gaze like she's looking at something very far away and very small. The patient in 340 is your son's age, she says quietly. I hope someone speaks up for him when it matters. Then she walks away. The corridor seems to contract in her absence. The junior doctors exchange a glance. One of them, The younger one, third-year resident named Kowalski, watches her disappear around the corner and makes a note on his personal phone. Not for Pierce. For himself. For later, when he's trying to figure out what just happened. Pierce stands motionless at the vending machine, the fluorescent lights humming their mechanical song above him, and for the first time all day, his expression is something other than controlled superiority. It's the look of a man who's realized, in a moment of perfect clarity, that he may have miscalculated something fundamental. But he doesn't have time to dwell on it. He never allows himself that luxury. The next morning, Pierce schedules a lunch meeting with Director Chen, the nursing director who oversees all floor staff assignments and credential verification. They meet in the hospital cafeteria, at a small table near the window where the afternoon light makes everything look softer than it really is. Pierce orders the salad. Chen orders soup. Neither of them eats much. I wanted to discuss some concerns, Pierce begins, his voice now carefully modulated into the register of professional worry. About Nurse Clarke. I've been hearing things. Chen sets down her spoon. She's been at St. Michael's for 14 years and has seen enough hospital politics to know that when a doctor wants to discuss a nurse, the conversation has already been decided before it began. What kind of things? Rumors, mostly, Pierce says, which is always the most dangerous way to begin spreading facts. But I think we need to take them seriously. Her credentials, have you actually verified them? I've been told there may be some discrepancies in her background. Military service she claims, but nothing substantiated. She passed the initial background check, Chen says carefully. Initial checks can miss things, Pierce continues. He leans forward slightly, the posture of someone sharing a burden of knowledge. Particularly if someone was sophisticated enough to hide something. And the way she operates, the way she second-guesses physician orders, the way she seems to have knowledge beyond standard nursing protocols. It's concerning. Is it possible she's misrepresenting her qualifications? Chen frowns. She makes a note. Just the act of taking notes lends credibility to unsubstantiated concern. Pierce has learned that institutional paranoia is easy to cultivate if you know the right fertilizer. I'm not saying she's definitely done anything wrong, Pierce adds, the voice of measured reasonableness. But in a hospital, we have to be careful. Patient safety. Due diligence. I'd feel terrible if we discovered later that we missed something. That someone wasn't who they claimed to be. Chen nods. She's thinking about liability now. About the Joint Commission. About the insurance implications of credential fraud. Pierce watches her think these things and feels the familiar satisfaction of a trap being set correctly. I'll look into it, Chen finally says. Thank you, Pierce says. I just want to make sure we're protecting our patients. And our institution. The lunch ends. They don't finish their food. But the damage, the slow-moving, institutional damage that will take weeks to fully develop, like an infection that only reveals itself once it's already systemic, has been planted in exactly the right place. That evening, Hannah is back in the hospital for her shift. She doesn't know about the lunch meeting. She doesn't know that Pierce has shifted strategies, that he's moved from public humiliation to institutional sabotage, that he's activated a cascade of administrative scrutiny that will begin quietly and intensify gradually. She doesn't know that somewhere in the personnel office, someone is being asked to re-verify credentials that were never supposed to be verified, records that were never supposed to be found. What she knows is that she needs to check on the colonel. The intake paperwork arrived at the nurse's station at 7:43 a.m., 2 hours into Hannah's shift. Standard admissions packet, demographic form, insurance verification, medical history spanning for decades of military service. She registered the name first. Then the rank. Then the unit designation, and her hands went very still. Colonel James Halloway. 3rd Special Forces Group. Admitted with acute respiratory compromise secondary to fungal lung infection, a parting gift from 2 decades of deployed breathing, from caves and forward operating bases and the dust of the Hindu Kush that never quite left a soldier's lungs no matter how many years passed. The admitting note mentioned fever spiking to 104.2, oxygen saturation dropping into the low 80s, and a scheduled bronchoscopy for Tuesday morning to identify the infection source. She read the name 3 times to be certain. Holloway. The colonel who had sat across from her kitchen table on a Tuesday afternoon 19 years ago, dress uniform pressed so sharp it could cut, and told her that Lieutenant James Clarke had been killed in action during a recovery operation in Loga Province. The man who had written the letter, the official one, the one with the Pentagon seal and the careful words about honor and sacrifice and service above self. The man whose voice had cracked exactly once when she asked him if there was a body to bury. The paperwork trembled in her fingers. Not from fear. From recognition. Hannah set the packet down on the desk and pressed her palms flat against the cool laminate surface. The fluorescent lights hummed overhead, their frequency a constant white noise that most people learn to ignore within weeks of working hospital nights. She had never learned to ignore it. It sounded like the ventilators in the ICU, like the mechanical breathing of people hanging between moments. His room assignment was 340. The same room. The same one where she had stood 2 weeks ago and suggested a different anticoagulant dosage to Dr. Pierce, the one where he had loudly threatened security and escorted her out. The one where he had made his point clear, nurses existed to execute orders, not to think. She pulled the colonel's chart toward her and began the initial intake protocol, vitals review, medication reconciliation, equipment preparation for the bronchoscopy scheduled in the ICU. Her fingers moved through the motions with the automatic precision of someone who had performed the same task 10,000 times. Name, date of birth, verify allergies. The ritual that kept her grounded. But her mind was 19 years and 3,000 miles away. In a Chinook helicopter flying low over the Spingar Mountains. In the debrief room where she had sat for 8 hours while men with no name tags asked her questions about an operation that didn't exist. In the moment when her commanding officer had explained, very carefully and very finely, that Captain Hannah Clarke was being scrubbed from every record. That her service would be classified. That her son's death would be listed as killed in action, which was true, but not in any way that could ever be spoken aloud. That she would disappear into a civilian life and never surface, regardless of circumstance. Muscle memory took over. She gathered the chart, double-checked the room number, and walked toward the ICU. The hallway smelled like antiseptic and something else underneath it, the particular staleness that came from filtered air recirculated too many times. Her boots, standard white leather nursing shoes, nothing military about them, made soft squeaking sounds on the tile. The colonel was sitting up in bed when she entered room 340, oxygen already running at 2 liters through a nasal cannula. He was smaller than she remembered, though that was always how it went with men who had been larger than life. Time and illness reduced them to their actual dimensions. His grey hair had thinned. His hands, lying atop the blanket, bore the texture of someone who had gripped rifle stocks and climbing ropes and the harnesses of men being extracted from fire. He looked at her and something flickered in his eyes. Recognition, maybe. Or just the baseline courtesy that came from decades of military politeness. "Morning, Colonel," Hannah said, her voice steady, her hands moving through the assessment with clean efficiency. Blood pressure cuff. Pulse oximetry probe on his index finger. Thermometer. "I'm going to be supporting your care while you're with us. How are you feeling this morning?" "Like my lungs are staging a mutiny," he said. His voice was rough, bronchial, the voice of a man whose breathing had been compromised for weeks. "But I've survived worse." The procedure's at 9 a.m. Dr. Pierce will be performing the bronchoscopy. She attached the SpO2 monitor and watched the numbers climb to 91. "Good. Stable. We'll prep you about 30 minutes prior. NPO after midnight tonight, nothing to eat or drink." "Understood." He paused. "You have the look of someone who's seen a field hospital." Hannah's hands didn't pause. "Military family," she said, which was true. "Lost someone?" "Yes." The colonel nodded slowly, the way older men did when they had been in places where losses were measured in body counts. "I'm sorry." She finished the vitals check and stepped back from the bed. The respiratory therapist will be in at 8:30. If your oxygen drops below 90 or you have any chest pain, use the call button. I'll be monitoring. What she didn't say, I know who you are. I know why you're here. I know what you did that day, and I know what it cost you. What she didn't say, I have 19 years of questions and nowhere to put them. The chart went back to the nurse's station. Hannah was reviewing the pre-procedure checklist when Dr. Pierce appeared in the doorway of the ICU, his presence announcing itself before he did, the way certain people carried a kind of atmospheric pressure that made the air feel heavier. His eye scanned the patient census board and found the colonel's name. His jaw tightened. Hannah, he said, and the fact that he used her name instead of nurse made something in her chest go cold. The Holloway patient. Yes, Dr. Pierce. You'll be reassigned for the procedure. I want Rodriguez on support instead. You'll chart from the desk. The colonel is assigned to room 340. I've already begun his intake. Continuity of. You're reassigned. This isn't a discussion. He turned away, then stopped. And Hannah? When this patient mentions you were caring for him, I'd appreciate it if you made clear that you were following protocol, nothing more. No independent assessments. No suggestions. Just monitoring equipment. She understood. He was building a record. Establishing that if anything went wrong, she had been sidelined. Benched. Powerless. Understood, Dr. Pierce. But that wasn't the worst part. At 8:08 a.m., 2 minutes before the bronchoscopy was scheduled to begin, the colonel's oxygen saturation dropped to 88. The monitor beeped once. Twice. Hannah was charting 3 feet away, watching the numbers slide downward like a slow-motion fall. She moved to his room, already reaching for the emergency call button. Everything okay, Captain? He asked, and there it was, the smallest slip, the single word that meant he remembered after all. Staying with you, Colonel, she said quietly. Just staying with you. The respiratory therapist arrived with the portable equipment. Rodriguez, the nurse Pierce had demanded. The procedure team assembled in the ICU treatment room, controlled chaos of machines being wheeled into position, the crash cart station just outside, the careful choreography of people preparing for a crisis that might or might not happen. Pierce arrived at 9:01 a.m. with the demeanor of a man already annoyed at being 3 minutes late to his own show. He didn't look at Hannah. He didn't have to. She was already supposed to be invisible. The bronchoscope was a slim tube fitted with a camera and light source, designed to travel down the trachea and into the lungs to visualize, sample, and identify the infection source. A routine procedure. People did these thousands of times a day in hospitals across the country. Hannah stood at the perimeter of the procedure room, officially present, officially silent. Rodriguez had the vital signs monitor. Pierce had the scope. The respiratory therapist had oxygen and suction equipment. The colonel was already sedated, his breathing supported by supplemental oxygen, his chest rising and falling in the mechanical rhythm of controlled anesthesia. Pierce inserted the scope with the deliberate precision of a man performing for an audience. His technique was clean. His hand positioning textbook. Everything by the book until the moment it wasn't. 30 seconds into the procedure, the colonel's oxygen saturation dropped to 85. Rodriguez called it out, "O2 sats falling, doctor." Pierce didn't look up. "Monitor your equipment, nurse. The scope hasn't advanced past the cords yet." But Hannah saw what Pierce couldn't see from his angle. The chest wall wasn't moving symmetrically. The right side, normally expanding and contracting with breath, was silent. Motionless. She moved closer, positioning herself where she could see the colonel's neck. The trachea was deviating. Pushing left. The classic sign of pressure building on the right side of the chest, pressure that shouldn't be there. "Dr. Pierce," she said, her voice even, clinical. "Tension pneumothorax. Monitor your equipment, nurse." But Pierce's hand had slowed. 82. The numbers kept falling. 80. 78. The Colonel's lips were turning blue. Pierce withdrew the scope in a movement that wasn't smooth anymore, wasn't controlled. His eyes were wide. His breathing had changed. Chest tube set up. Now. They moved. Rodriguez grabbing the insertion kit. Pierce positioning himself at the second intercostal space, mid-clavicular line, the standard landmark for emergency decompression. His hands were shaking. She could see it from 8 feet away. 45 seconds. 50. The Colonel's oxygen was a red digital scream. 59%. 56. Pierce was fumbling with the needle insertion, missing the anatomical landmark, his technique unraveling in real time as panic rewired his nervous system. The angle was wrong. The depth was wrong. He was running out of time and he knew it. Hannah closed her eyes for exactly 1 second. When she opened them, she was already moving. She crossed the room in 4 steps, her hand closing around the number 10 scalpel from the instrument tray. The weight of it felt like coming home. Pierce shouted something, "What the hell, what are you?" but his voice was already distant, already irrelevant. She made the incision at the 5th intercostal space, lateral to the mid-axillary line, the muscle memory of 19 years taking over her hands. Muscle memory was different from learning. It lived deeper. It lived in the nervous system, in the cells themselves, in the hands that had done this same procedure in a cave outside Jalalabad while RPGs were detonating against the rock walls and someone was screaming that they were running out of blood. The rush of air escaping. "Stay with me, Colonel," she said, her voice dropping an octave, becoming someone else entirely. "You survived the Hindu Kush. You survived this." She was already reaching for the thoracotomy retractors, spreading the ribs, accessing the pleural space, her hands moving through each step with the terrible precision of someone who had done this in darkness, in cold, with artillery shaking the ground. The massive air leak sealed itself. Oxygen saturation climbed. 85. 88. 92. Pink returning to his lips. His pupils reactive. His heartbeat, there, steady and strong on the monitor. Sinus rhythm. The room had gone completely silent except for the monitor beeping and the sound of the Colonel's breathing, now controlled, now oxygenated, now alive. Pierce was standing with his back against the wall, his face white, his hands hanging at his sides like they belonged to someone else. "Call surgery," Hannah said to Rodriguez, her voice carrying the weight of command. "Tell them we need a trauma surgeon down to the ICU in the next 2 minutes. Tell them we have a tension pneumothorax with traumatic perforation that requires a thoracotomy." She paused. "Don't tell them who performed the initial intervention." But that wasn't the worst part either. The worst part was that everyone in that room knew exactly what they had just witnessed, and not one of them, not Rodriguez, not the respiratory therapist, not a single witness, would forget it. The bronchoscopy was scheduled for 0900. Hannah arrived at the procedure room at 08 for 5, her hands already moving through the pre-op checklist with the automaticity of someone who had done this 200 times. Sterile field. Monitors. Sedation ready. The ventilator hummed its low mechanical drone in the corner like a sleeping beast. She had worked this room for 3 years without incident, and she would work it today the same way, perfectly. Dr. Pierce entered at 0858, his presence preceded by the sharp smell of expensive cologne cutting through the antiseptic air. He saw Hannah and his jaw tightened. "I need a different nurse. Get Rodriguez." Hannah didn't look up from the instrument tray. "Rodriguez is in Trauma Bay 2. I'm assigned here. I don't care if she's on the moon. Find someone else." The charge nurse, standing near the door, cleared her throat. "Dr. Pierce, Hannah certified for cardiopulmonary procedures. Her record is—" "I'm aware of her record." His voice dropped an octave, the way it did when he was being careful to sound reasonable. "I simply prefer continuity with my regular staff. It's a matter of protocol." Hannah placed the last instrument on the tray and looked at him with the kind of flat stare that had once made Taliban interrogators confess. The colonel needs the bronchoscopy at 0900. The window closes after that. You have 90 seconds to decide if we're doing this today. The room went dead silent. 54 seconds of silence. Nurses and tech staff became very interested in the floor tiles, the ceiling, anywhere but her face. Pierce's neck reddened, but Hannah's voice had been so calm, so free of challenge or emotion, that responding with anger would have made him look unstable. He nodded once, sharply, and turned toward the prep area. The colonel was wheeled in at 0903, already sedated, his massive frame looking oddly vulnerable under the surgical lights. He was a man built from decades of command, shoulders like a lineman, hands scarred from a life spent in places where softness got you killed. Hannah had recognized him the moment he was admitted, though she hadn't let her face show it. Lieutenant James Clarke's commanding officer. The man who had signed the letter explaining why her son would never come home from the Hindu Kush. "Let's get him positioned," Pierce said, his voice sliding back into its surgical register, all precision and authority. Hannah moved with him, her hand steadying the colonel's head while Pierce worked the scope into position. The monitors sang their continuous electronic chorus. O2 sat 97. Heart rate 72. Baseline vitals, clean and steady. The scope went deeper. Pierce was competent, she would give him that. His hands were steady as he maneuvered the endotracheal tube, his eyes fixed on the monitor showing the colonel's upper airway. Clear. No masses. No obvious obstruction. Oxygen saturation is holding, Hannah noted, watching the number on the screen. 96. 95. Good airflow. Then the ventilator's rhythm changed. It was subtle, a fractional hesitation, barely perceptible to anyone who hadn't learned to hear the difference between normal and critical in the space between heartbeats. Hannah's hand moved to the monitor. Oxygen sat 91. Dropping. 88. 84. Dr. Pierce, his SATs are tanking. He's fine. The scopes just, but even as he said it, the number fell further. 80. 78. The monitor's alarm began its high, insistent chirp, 3 rising tones, repeating, demanding attention. Tension pneumothorax, Hannah said. Not a question. The colonel's lung was collapsing, air trapped in his pleural space with nowhere to go, crushing the tissue, compressing the vessels that fed his heart. We need to decompress. Pierce's hands moved to the chest tube kit, but they were moving wrong, fumbling, the precision gone, replaced by something that looked like panic disguised as haste. His fingers scraped the needle, knocking it against the metal tray with a sharp clink. 72. 68. The colonel's blood pressure was dropping along with his oxygen. Pierce positioned the needle at the second intercostal space, but his hands were shaking just enough that the angle was wrong, the insertion hesitant, a man performing a procedure he had trained in but never truly believed he would need to execute. The needle went in. Nothing. No hiss of air. No decompression. The numbers kept falling. 64. 60. The rhythm on the cardiac monitor began to slow, the spaces between beats stretching like a held breath that wouldn't release. Hannah didn't think. Thinking was a luxury for people with time. Her hand moved to the instrument tray and closed around the scalpel, the same type of blade she had used in a cave system outside Jalabad, bleeding light from a tactical flashlight across a wounded Marine's chest while mortar rounds echoed off the stone walls above. She had coordinated 3 medevac extractions from that valley. 3 birds rotating through under fire, no casualties, every one of those soldiers still alive because her hands had remembered what her mouth was forbidden to speak. Move, she said to Pierce. Not a request. A command delivered in the voice that once coordinated life or death decisions over radio frequencies that didn't officially exist. He stared at her for one fractured second, then stepped back, and Hannah was already in the space he vacated, the scalpel in her right hand moving with the kind of terrifying fluid precision that comes from muscle memory so deep it transcends thought. Left anterolateral thoracotomy. Fourth intercostal space. The blade went in with a whispered friction, skin, subcutaneous tissue, the intercostal muscles parting with the slightest resistance. Blood well dark and immediate, but she was already past that, her left hand spreading the incision, the scalpel dropping to the tray and a hemostat appearing in her grip as naturally as breathing. The pericardium came into view, and she was talking now, her voice steady as river stone, saying the things a wounded soldier in a cave needs to hear to believe he will survive. "Colonel, you've got a pneumothorax. I'm going to release the pressure. You're going to feel pressure and pain. That means it's working. Stay with me." 63. 62. The numbers falling like a countdown to something none of them wanted to reach. She found the collapsed lung, dark and airless, a silent protest against the trapped air crushing it. Her fingers moved with surgical precision, finding the source of the pneumothorax, a small laceration in the visceral pleura bleeding air into the pleural space with every breath the ventilator forced into him. She packed the wound with gauze, her voice never wavering, speaking to the colonel like they were alone in the operating room instead of surrounded by 5 surgical staff members and Dr. Pierce whose face had gone the color of old bone. "Air stopping. You're going to feel your lung re-expanding. The pain will decrease. Focus on the monitors. Watch your oxygen saturation climb. 75. You're doing good, Colonel. Just like we trained for." 76. 78. 82. The numbers rising now, climbing back toward the land of the living. The monitor's alarm fell silent. The colonel's blood pressure steadied, then strengthened. The hiss of air escaping, the sound that meant the pneumothorax was resolving, the pressure equalizing, the lung inflating and reasserting itself like a fist unclenching. 88. 91. 94. Hannah didn't stop working. She closed the incision with the methodical precision of someone for whom speed and control were not opposing forces but the same thing. Sutures. Gauze. The wound sealed, the crisis moving from acute to managed to resolved. Her gloved hands were slick with blood, but they moved like they belonged to someone else, someone who had trained for years in a place that didn't officially exist, for operations that would never be in any record, for a life that she was supposed to leave behind the moment she accepted the new identity and the cardboard discharge papers and the order to disappear. She stepped back from the table. The scalpel was still in her right hand, the blade catching the surgical light like it was holding something luminous. For 3 heartbeats, the room didn't breathe. The monitors sang their steady, reassuring song. The colonel's vitals climbed toward baseline. The respiratory therapist checked the ventilator settings and nodded without speaking. One of the surgical residents, a woman named Cho, 26 years old, brilliant and careful, was staring at Hannah like she was trying to remember if what she had just witnessed was real or some kind of elaborate hallucination. Then Dr. Pierce moved. His voice came out low and controlled, which was somehow worse than if he had shouted. "Get her out of my operating room. Now." Hannah placed the scalpel on the instrument tray with the care of someone setting down something sacred. Her hands were still steady. Her breathing was still level. The only thing that had changed was her eyes. They had shifted from the careful neutral expression of a civilian nurse to something else entirely, something that looked at Dr. Pierce like he was a problem to be calculated and solved. "The colonel is stable," she said. "The procedure can continue if you'd like to complete the bronchoscopy, or we can wake him an." I said get out. Pierce's voice rose 3 octaves on the second word, betraying something beneath the surface that wanted to crack. "Security. Now. Get security to the OR and remove her." The charge nurse moved toward the phone, her movements reluctant, her eyes fixed on Hannah's face like she was trying to memorize it. Hannah began removing her gloves, the outer pair first, the blood-soaked latex peeling away to reveal the clean latex underneath. She was already calculating the timeline. Pierce would act before she made it to the locker room. He would need to act, because what had just happened in this operating room couldn't be tolerated, couldn't be explained, couldn't be allowed to stand as fact in the institutional record of St. Michael's Hospital. She had saved the colonel's life. That was the problem. She had saved his life in a way that no one on his staff could have, using knowledge that she wasn't supposed to possess, with a competence that didn't fit the narrative he had constructed. And in that moment, standing in the middle of his operating room with blood still wet on her arms and 3 years of careful invisibility burning like a cigarette in real time, Hannah Clarke understood that the war she thought she had left in the Hindu Kush was not over. It had simply followed her home. Pierce moved through the hospital that evening like a man conducting his own autopsy. His hands were still shaking, a detail he would never admit, and rage had crystallized into something colder and more dangerous than anger. In his office, door locked, he made the first call at 6:11 p.m. to James Bancroft, a board member whose daughter Pierce's surgical skills had saved from a ruptured aorta 3 years prior. Bancroft answered on the second ring. "James, I need a favor. Tonight." The line crackled with the sound of ice in a glass. Bancroft had been drinking. Pierce laid it out with surgical precision. A nurse, Hannah Clarke, had just performed an unauthorized procedure in his operating room, violated chain of command, and posed a liability risk to the hospital. "I need you to pull her credentials. Contact the state nursing board. I'm launching a formal investigation." Bancroft hesitated for exactly 2 seconds. Then, "Done. You have it." The second call went to Dr. Catherine Wells at the Medical Review Committee. The third to Robert Chen, the hospital's legal advisor. By 8:15 p.m., Pierce had activated a network of people whose careers he had once elevated, whose families he had once saved, people who now owed him the kind of debt that moves mountains. He also contacted a private investigator, $8.47 per day, cash, no paperwork, with a single directive: prove she's a fraud. "I want everything. Every reference. Every credential. I want criminally prosecutable evidence." What Pierce did not understand, what his fury had blinded him to, was that he was holding a weapon aimed at his own chest. By 7:33 p.m. that same evening, Hannah stood in the nurse manager's office as Patricia Okonkwo, the night shift supervisor, placed a suspension letter on the desk between them. The letter was dated that afternoon, stamped with hospital legal seal, and notarized. Effective immediately, pending formal investigation. "You're not to enter this hospital. You're not to contact patients, staff, or Patricia couldn't finish." Her hands were trembling in a way Hannah's were not. Hannah folded the letter once, then again, and placed it in her scrub pocket with the same care a sniper uses to chamber a round. "How long?" Patricia swallowed. "Until the investigation concludes. Could be weeks. Could be months. Hannah, I don't understand what happened up there. I need you to tell me something was wrong. I need you to tell me that procedure wasn't." Hannah stood. Her voice, when she spoke, was flat as a runway. The colonel would have died without it. "You know I'm right." Patricia turned away. In the fluorescent hum of the office, under lights that had witnessed 1,000 difficult conversations, Hannah moved toward the door. And that's when Pierce found her in the corridor. He was still in surgical scrubs, still wearing the boots he'd worn into the OR, and his face was the color of raw meat beneath the fluorescent panels. He positioned himself between Hannah and the elevator with the deliberate choreography of a predator blocking an escape route. Orderlies and passing nurses began to sense the temperature drop and found urgent business elsewhere. "Walk with me," Pierce said. It wasn't a request. They moved through the corridors of St. Michael's like two fighters entering a ring, and Pierce guided her toward the main exit, the one used by patients who were leaving for palliative care or discharge to hospice, the exit for people going nowhere good. Hospital security stood at the door, briefed and waiting, though no one had called them. Pierce walked her to the threshold where the automatic doors hissed open like a serpent's breath, and Atlanta's evening heat rolled in carrying the smell of diesel exhaust and approaching rain. "Don't come back," Pierce said, his voice so quiet other people had to lean in to hear it, which was exactly the point. Everyone saw Hannah Clarke, the quiet nurse, the one no one really knew, being escorted from the building by her superior. Everyone saw the narrative Pierce was writing in real time: guilt, insubordination, dangerous autonomy. He watched her move down the wheelchair ramp toward the parking lot and felt the surge of satisfaction that comes from successfully destroying something you fear. He did not watch long enough to see what happened next. Hannah sat at the bus stop on Peachtree Street at 8:41 p.m., rain beginning to fall in sheets that turned the asphalt into a mirror. The cardboard box she'd carried from her locker was disintegrating, the bottom corner growing soft and dark with moisture. Inside, a cracked ceramic mug that read "World's Best Mom" in fading gold lettering, a succulent that had been dying since February, and a framed photograph of James in his dress uniform, 23 years old forever, frozen in the moment before the Hindu Kush and the IED, and the letter that began, "Dear Mrs. Clarke, it is with profound regret." She didn't cry. The rain was enough. It fell on her shoulders, beaded on her scrubs, and she held the photograph against her chest the way soldiers hold something alive that is already dead. The call came to St. Michael's Administrator Richard Hoffman at 10:03 p.m. from a woman named Dr. Sarah Vance, who identified herself as working in the Personnel Security Division at Bethesda Naval Hospital. Her voice was precise, federal, the kind of voice that does not repeat itself. "We're flagging a situation at your facility. During a background check for an employment investigation, a classified security clearance was detected in federal databases under the name Hannah Clarke. The clearance is current. The individual in question appears to have been ordered to maintain civilian status with minimal identification. We need clarification on what investigation you've initiated and why." Hoffman had gone pale. He pulled up the files on his desktop, the investigation into Hannah Clarke, the suspension, the recommendations from Dr. Pierce to prosecute. Then he looked at the classified clearance notation, at the agency name he couldn't quite pronounce, at the line that read Operation Nightingale, details classified. The rain continued at the bus stop. The photograph grew heavier in Hannah's hands. Colonel James Halloway woke at 12:17 a.m. with chest pain, not cardiac, just the pulling sensation of healing ribs and a thoracotomy incision that was learning to knit back together. In the darkness of his ICU room, 2 Marines stood as sentries, a precaution no one had explained to the night shift. When Pierce burst through the door at 12:31 a.m. demanding answers about what happened in the operating room, demanding to know what authorization Hannah Clarke had, the colonel raised his hand with the kind of authority that comes from commanding men in firefights. "Step back, doctor." Pierce did not step back. "That nurse compromised my operating room. She performed an unauthorized," the colonel spoke one word. "Valkyrie." In the monitor's blue glow, both Marines came to attention with the hydraulic precision of people trained to respond to a specific call sign. The older one, Staff Sergeant Marcus Webb, pulled his phone from his pocket and dialed without looking away from Pierce's face. "Sir, I'm notifying command that Captain Clarke's operational security has been compromised." Pierce felt something ancient in his mind recognize the shape of his own danger, but it was too late. The machinery was already turning. At 6:38 a.m., as dawn broke over Atlanta in shades of amber and ash, Staff Sergeant Webb stood in the hospital's administrative conference room reading from a classified document that had been faxed from the Pentagon to Hoffman's secure line. 3 board members sat silent. Patricia Okonkwo sat silent. Hospital legal sat silent. Pierce, summoned to the conference room and now understanding that something had fundamentally shifted, watched the staff sergeant's jaw work through the words. Captain Hannah Clarke received the Silver Star for valor under fire. Webb paused. The room held its breath. She received the Defense Superior Service Medal for an operation that, the document cut off at the next line, redacted in black ink so thoroughly it looked like a scar. Pierce's face had drained to the color of old bone. "This is fabricated," he whispered. "This is impossible." But his hands were shaking again, and this time everyone could see it. The investigation Pierce had launched began to turn with the inexorable logic of a flywheel changing direction. The private investigator, now informed through hospital counsel that his target was a decorated combat veteran, developed a sudden and complete loss of interest in the case. The 3 board members Pierce had called in favors from began reviewing the rationale they'd been given and found it thin as rice paper. Patricia Okonkwo pulled her own notes from her lunches with Pierce and saw with horrifying clarity how she had been manipulated, how Pierce had systematically positioned her to distrust every nurse who made him look bad by comparison. She provided sworn testimony to hospital administration. The State Medical Board, alerted by hospital legal to potential complications in Pierce's surgical records, opened a formal investigation. They pulled 5 years of surgical outcomes. They pulled chart documentation. They found a patient death 18 months prior, a routine bypass that had gone septic, attributed by Pierce to poor postoperative nursing monitoring, a charge he had made stick hard enough that a surgical nurse named Janet Morrison had quietly resigned rather than fight. They found altered notes in her chart. They found infections that should not have developed from his technique. They found the fingerprints of someone creating alibis in real time. By Thursday of that week, Pierce's medical license carried a restriction: he could not perform surgery. He could not supervise surgical residents. He could not practice clinical medicine until the board investigation concluded. His wife received a copy of the suspension notice, standard procedure, and suddenly the architecture of his perfect life, the dinner parties, the country club membership, the dean's recognition, began to list and collapse like a building losing its load-bearing walls. He came to the hospital on Friday morning demanding access to records, demanding to review his cases, demanding vindication, and found that his badge no longer worked. Security, the same security that had escorted Hannah out days earlier, now escorted him out instead. He stood in the parking lot as rain began to fall again, holding a cardboard box containing his nameplate and a photograph of himself receiving the Chief of Surgery award, and understood that what Hannah had taken from him was not his reputation. It was his identity. It was the single story he had told himself about who he was. 18 months passed. Hannah Clarke now worked as St. Michael's trauma coordinator, redesigning protocols based on the combat medicine she'd learned in valleys where the nearest surgeon was an hour away by helicopter. Response times in critical cases dropped by 40%. Resident mortality rates dropped by half. The colonel visited quarterly, always carrying coffee, always carrying stories about James and the men James had saved, always pressing the same question, ready to talk about that transfer to Walter Reed. Hannah smiled the smile of someone who had already been to war twice and found that home could be a good place if you built it carefully enough. In her new office, she kept the faded 3rd Special Forces group patch she'd found sewn inside the colonel's jacket lining, a unit that had saved her son, a unit that had made him who he was, framed beside his photograph. She spoke to that photo most mornings, not the way broken people talk to ghosts, but the way soldiers talk to the people still standing beside them. Dr. Marcus Pierce now taught CPR certification classes at Atlanta Community College for $15.32 per hour. His medical license was restricted to non-clinical education only. He was not allowed to touch patients. He could teach mannequin compressions to bored undergraduates who did not know he had once been chief of cardiac surgery at one of the region's most respected hospitals. He saw Hannah's name in a medical journal, an article on trauma protocols adopted by 3 VA hospitals, protocols that would save lives for the next 50 years. A student raised her hand during break. "Dr. Pierce, why aren't you working at a hospital?" He had no answer that didn't destroy him further, so he said nothing and returned to the CPR dummy, pressing its chest in perfect rhythm, trying to remember what it felt like to save something alive. Hannah stood in the trauma bay during a mass casualty incident at a warehouse fire with 37 injured, directing residents with that voice that had once coordinated medevac extractions under fire. A young nurse named Sophia hesitated over a critical decision, hands trembling, and Hannah placed a steady hand on her shoulder. "Trust your training. Trust what you know." Sophia's hand steadied. The patient lived. Later, in the quiet of her office, Hannah touched the frame holding James's photo and the unit patch, and spoke words she'd carried from a cave system in Jalabad to a surgical suite in Atlanta to a rain-soaked bus stop and now here, to a place where she could finally say them aloud. Power is not a title. Power is the ability to help. Outside, St. Michael's hummed with the fluorescent lights and antiseptic that sound like hospital music, and somewhere in this place, someone nobody noticed was saving a life, was holding the line, was doing the work that changes everything because no one is watching. That person was free. If this story moved you, if you've ever been underestimated by someone who didn't know your true value, I need you to subscribe and hit that notification bell so you don't miss the stories of the quiet warriors walking among us. Drop a comment below. What would you have done in Hannah's position? Like this video and share it with someone who needs to hear that real power doesn't come from a title, it comes from what you do when the world stops watching.